Bismillahirrahmanirrahim. Dear students, due to some internet connectivity issue, I'm going to start this class again. So in this topic, we will discuss about how to approach a patient uh, with tuberculosis if he is a child. So as you know that tuberculosis is caused by Mycobacterium tuberculosis, that is tubercle bacilli. This is a chronic granulomatous disease. So mode of transmission is very clear that it is spread by droplet method. That means when an infected person who is having pulmonary tuberculosis and he has cavitation lesion, usually it's a cavity in the lungs which is spitting out tiny mycobacterium tubercle germs into air when person coughs or sneezes. So when that droplets are taken up by a healthy person, he is at risk of developing this disease. Mostly tuberculosis is caused by inhalation, but at times these cases has been reported in literature, which are caused by taking infected cow milk. So if we talk about symptoms of tuberculosis, almost the most common is pulmonary tuberculosis. Almost 75% cases are of pulmonary tuberculosis. Mostly these are asymptomatic or they are diagnosed after contact screening of family member. If we talk about respiratory symptoms, these children usually have shortness of breath, sometimes they have cough, fever, and chest pains. But there are other symptoms which are called constitutional symptoms. These are not specific to chest, but these are general signs and symptoms. Usually patient report loss of appetite. Parents will say that our child is not getting weight. They will have history of fever, which is sometimes documented and sometimes it is not documented. They may report about poor activity, fatigue, and night sweat. 25% patients, they have extrapulmonary tuberculosis. And it's very important to understand that symptoms are only specific to that specific area which was involved by tuberculosis. Like if we talk about lymph nodes TB, patient usually have swelling of a specific area like cervical swelling, axillary swelling, or inguinal swelling. Sometimes when disease is process is quite old, patient may have pus coming out of that infected lymph nodes. If we talk about pleural effusion, patients usually have dry cough, they have shortness of breath, they may report heaviness or dull, non-specific chest pain on that affected site. If we talk about joint TB, usually a single joint is involved. Patients usually have chronic movement issues. Patient may have pain, swelling of affected joint. In case of tuberculosis meningitis, you may get history of headache, fever, neck stiffness, and at times altered behavior is documented. Similarly, in case of spinal TB, patient usually have low back pain, patient may have loss or decreased function of lower limbs, bowel and bladder involvement, and on examination you can document gibbous. Gibbous is a specific prominent area of spine which is produced because of fusion of two or more infected spines. Similarly, if genital tract is involved, uh, they may present with infertility in teenage group or in fertility age group. When should TB be suspected in a child? This is a very common but very tricky question. We suspect TB as a passive case, like when patient have unexplained illness and we document signs of TB. Second time, at patient usually they come to us with his X-rays and that they are suspecting TB in their family members. And so this is the X-ray, and X-rays of chest are showing specific extensive lung damage, which is consistent with tuberculosis. Similarly, when we are dealing a patient of tuberculosis and we want to screen household contact. So these are three common scenarios when we suspect tuberculosis. So this is a chart which is Pakistan Pediatric Association chart. And if you just look at this thing, this is a very helpful tool, and this was developed by Pakistan Pediatric Association from it has two sections. One is history and second is examination. In history, age, if it is less than 2 or more than 2, close contact in last 2 years with T patient or with T patient who is sputum positive, whether BC scar is present or absent, history of measles and whooping cough. These two disorders produce severe immune dysfunction. So between 3 to 6 months, it has 1 marks, and less than 3 months, it has 3 marks. Similarly, patient is immunocompromised or on drug therapy, which is producing immunocompromised state. Protein caloric malnutrition, which is present, yes, and if it is not improving, it will carry 3 marks. Similarly, physical examination, which is strongest suggestive of tuberculosis or simple suggestive of TB. Radiological finding, which is non-specific like any other pneumonia or specific for tuberculosis. Similarly, what is the status of MON2 test or tuberculin skin test? And granuloma, this is picked up by histopathology when we take out sample from cervical or axial lymph nodes or spine. So these charts are of value when you are working in pediatric ward. We will ask about these charts, so try to memorize this chart in very well. So if we calculate numbers from history and examination and total numbers are less than 2, then the chances that this patient has tuberculosis is less likely. If it is 7 or more, then this is a confirmed case of tuberculosis. You need to go for gastric aspirate, or you need to go for gastric aspirate, or you need to do some sputum for AFB before starting treatment. So if you want to diagnose tuberculosis in children, you should take good history, perform good examination. Is there any history of close contact in family? Perform tuberculin skin test, get chest X-ray, and pathological examination of sputum or gastric aspirate for AB. Usually, we suggest that you should ask your patient to take early morning sample of sputum or gastric aspirate by passing NG tube and send it for AFB and culture. If we talk about interpretation of skin test, it has if measurement of this induration is more than 5 mm, this is significant in those children who have recent contact with infectious adult patient. If patient has abnormal chest X-ray, or if patient is on case of leukemia, lymphoma, then even more than 5 mm is considered significant. But in Pakistan, if patient does not have any other high risk factors but has sign and symptom and living in Pakistan, then more than 10 mm is considered positive. Similarly, these are other important conditions in which we consider 10 mm as positive MON2 test. However, if there is no risk factor and it is more than 15 mm, then this is also considered significant. So other tests which we carry out are CBC, ESR. CBC, ESR, they are not diagnostic for tuberculosis. So these are just giving us an idea about whether what is the status of inflammation. There is another test which is called quantiferon gold test. This is offered by private labs like Han, Shifa International, and Excel Lab. These are quite expensive, but this is helpful in almost 85% cases. It is going to tell us about infections and whether it is active or not. Similarly, a rapid diagnostic test of TB, which includes serology and PCR, but these are not very specific and they are not routinely available. Uh, Mostly, these are for experimental purposes. Similarly, bronchoscopy is required in complicated or in those conditions when we are unable to find confirmed diagnosis. There's another condition which is called screening. So, when we come across a patient who has tuberculosis, we need to screen family member. Contact should be screened if he has symptoms suggestive of TB, then all age group should be screened. If child has TB and he has contact who is children, who is child and age is less than 5, he should be screened. If a child is or any person is suffering from immune compromised condition, similarly, contact of those person who has MDR TB, multi-drug resistant TB, they should be screened. So these are algorithms which are helpful when you are dealing with children. So when you suspect TB, first of all is administer Mantoux test. If it is more than 10 mm, do chest X-ray, sends gastric aspirate or sputum for AFP, apply PPA score. If AFP sputum is positive, gastric aspirate is positive, or chest X-ray and PPA score suggestive of more than 7 score, then declare this patient as TB positive and register. Similarly, these algorithms are for your help, so always try to carry these algorithms in word and practice them. So, few terminologies which you should remember. One is bacteriologically confirmed TB patient. This is a person who has either declared TB case by positive AFP or positive culture or gene expert, which is positive from any labs. So this and all these cases should be notified. Similarly, a person is called clinically diagnosed TB case when we are unable to get positive AFP, gene expert, uh, or gastric aspirate test, but a person who is treating physician, he strongly suggests as a case of tuberculosis. Patient can be labeled as case of pulmonary tuberculosis or case of extrapulmonary tuberculosis. So these are some classification like new case is that person who has taken TB treatment for less than 1 month or who is not registered with TB program. Similarly, relapse is that person which uh, was previously treated for tuberculosis and declared cured or treatment completed and now diagnosed with recurrent case of TB. Treatment after failure is that person who is started on a retreatment regime after having failed previously category 1 treatment. So these are some important definitions which you, when you will come to what we will share for your uh, use and practice. If we talk about treatment of TB, you should consider that anti-TB drugs are always given in combination. You should correct. You should prescribe adequate doses, and treatment should be started according to specific category. And it is important to understand that anti-tuberculosis therapy, which is ATT, should be taken anti-stomach on regular basis for a specific time, which was prescribed by physician. So if we talk about different categories, we are going to discuss here category 1 only. This includes new cases of severe positive pulmonary and new cases of severe negative pulmonary TB with extensive lung involvement. Similarly, severe extrapulmonary TB cases and severe concomitant HIV disease persons are also considered in category 1. If we talk about treatment for category 1, it has initial phase, which is a combination of three drugs, that is isoniazid, rifampicin, and pyrazinamide. These are administered for 2 months, which means that 60 doses are given. Sputum smear is done at the end of 3 to 2 months. If sputum smear is negative, then continuation phase is started. After in continuation phase, we use two drugs, that is INH and rifampicin for 4 months. Total duration is 6 months. Category 2, 3, 4, these are very advanced disease treatment modules, which you will learn while you are working in wards, like during house job or during postgraduate training program. A few words about roles of corticosteroid in DOTS. If a person has endobronchial TB, if a person is suffering from miliary TB, tuberculosis meningitis, involvement of pleura, then these patients should be given corticosteroids. DOT is a directly observed treatment therapy in which directly observed short courses of ATT in which a healthcare worker is supposed to give combination of drugs under his direct supervision. This was this process, that is DOT, was started to decrease relapses and to improve compliance, because mostly when patient become healthy, they stop ATT, or sometimes they do not take multiple drugs together in morning. So DOT was started to so that healthcare workers or a person who is responsible for giving medicine should give medicine under his supervision. So you should have 4 weekly follow-up, evaluate for treatment adherence and response to treatment. And also response to treatment is evident by weight gain, symptoms resolution, and you should request for sputum for AFP at specific time. You should weigh this your child on monthly basis. So these are different drugs and their doses. There is no need to go through these details. And now I will share these slides with you. All these details are present in your textbook. You can memorize these from your textbook. So if we talk about adverse effect, hepatotoxicity is quite common. It is called by INH pyrazinamide rifampicin. Vitreous problem is also quite common. Ethambutol is most notorious. Peripheral neuropathy, this is mostly because of INH, and we give pyridoxine, that is beta 6. Nausea, vomiting, neuropsychiatric issues, and joint issues are these minor issues which are sometimes evident. So most common is hepatotoxicity. In case of hepatotoxicity, you need to stop drugs. You need to monitor LFTs and reintroduce drugs step one by one, monitoring LFTs. So this is quite challenging, and it needs experience how to deal with a person who has developed raised LFTs or who has developed jaundice while taking ATT. So you will need all these by your experience. If we talk about hepatotoxicity, the most common and most toxic drug is INH. The incidence of hepatotoxicity is ranged from low to high or from high to low. Like this, INH is the most common, followed by pyrazinamide and then rifampicin. Ethambutol can be safely used in patients who have hepatic toxicity. Symptoms includes nausea, vomiting, decreased intake, dark urine, yellow skin discoloration. So INH should not be given with acute in a child who is having acute hepatitis and in end-stage disease. The first thing is you should go for LFTs. If results are less than 2 times upper limit and no side effect, repeat LFTs in 1 month. Consult with your physician when greater than 2 times upper limit. If any of LFT is more than 3 times upper limit of normal, stop ATT and uh, follow special protocol. During drug-induced hepatotoxicity is defined as ALT and AST more than 3 times upper limit of normal in the presence of symptoms. If symptoms are not there, then upper limit is more than 5 times. In case if a person reports with hepatitis, you should stop ATT, consult your that doctor or that physician who is expert in management of hepatotoxicity. You should evaluate for hepatitis A, B, and C. Rule out any other cause like any other hepatotoxic medication or alcohol consumption, and treat according to that specific cause. In acutely ill and acid-fast stent positive patient, two liver-friendly drugs can be used, that is levofloxacin and ethambutol. So if we talk about treatment outcome, we can label patient as a cured case. This is a person who is registered with TB program and he is smear positive. He has completed duration of treatment and becomes sputum smear negative at the end of treatment and on at least one previous occasion. Second scenario is treatment completed when a smear positive patient who has completed duration of treatment and has at least one follow-up smear negative result, but none at the end of treatment due to any reason. Similarly, smear negative and extrapulmonary cases who have completed 6 months of treatment successfully. Treatment failure is a person who has smear positive patient who remains and becomes smear positive at 5 months or later. Similarly, a patient who was smear negative initially but become uh, sputum smear positive after completing initial phase of treatment. So these are important definitions like cured, treatment completed, or treatment failure. You should remember these because these are going to help you not only in your clinical practice but in your exam. So if we talk about management of close contact, if we deal with close contact or adults, go for chest symptoms like cough for 2 weeks and other symptoms of TB, go for sputum smear test. If a person is contact is child and he has no symptom, then reassure, give BCG if not given already, prescribe INH in this dose and for 6 months. If child is less than 5 year of, if child is 5 year or below. If a child has symptom, then refer to specialist for treatment. If child is breastfed by some positive mother, then treat mother, protect child with INET by giving this medicine for 6 months. Continue breastfeeding at the end of 6 months. Give BCG if patient has not been vaccinated previously. If we talk about congenital and neonatal TB, congenital TB is acquired in utero by spread from umbilical vessel or at the time of delivery through aspiration of infected amniotic fluid. Congenital TB usually present in first 3 weeks and mortality is very high. Our neonatal TB is acquired after birth through an exposure to an infected person, usually mother, but patient can get from other close contact. Symptoms include lethargy, fever, poor feeding, low birth weight, poor weight gain. Sometimes they present with severe respiratory distress, non-resolving pneumonia, hepatosplenomegaly, abdominal distension with ascites, or any other picture of neonatal sepsis with disseminated TB. So if we talk about how to approach this, So to evaluate a baby for congenital TB, if evaluation is positive, like chest X-ray, tuberculin skin test, gastric aspirate, or sputum for AFB, and if this evaluation is positive, then you should treat for congenital TB infection. However, if evaluation is negative, then you should start INH and obtain MON2 test at the end of 3 months. If MON2 test is positive, re-evaluate for TB. If TB is positive, then treat for TB. If evaluation is negative, continue INH for 6 months. However, at the end of 3 months, if MON2 test is negative, then discontinue INH. So to conclude, the main objective of anti-TB treatment are: number one, to cure patient of TB, to prevent death from TB disease or its late effect, try to decreasing relapse of TB patient, prevent development and transmission of drug-resistant TB, which is very dangerous and very difficult to treat, reduce transmission of TB to others, and achieve all this with minimal toxicity. All children treated for TB should be registered with National TB Program. So I have skipped those important important slides which are not helpful for you or which are beyond your scope, and you will learn this during your post graduation in pediatrics if you are interested. And second thing is, all those important values are already given in your textbook, so you can consult your textbook at any times when you want to review them. Any question? So I will request GR and CR to mark attendance and share copy of this attendance to me and as well as to DME people.
Okay, sir.
If you are interested in having video of this lecture, let me know. Second thing is, if you want to have this presentation, I can share this presentation later on if you are interested.
Okay, sir.
Any question about this topic?